I think there are eminent neurologists, eminent psychiatrists, and many of them are my friends. And I just wonder how much I can contribute to this topic. However, your feedback is important because I will learn while sometimes you might also learn. The topic in question, it is neuroleptic-induced movement disorders, acute syndromes, meaning I won't be talking about the tardive syndromes. Acute syndrome encompasses acute dystonia, akathisia, drug-induced Parkinsonism, and neuroleptic malignant syndrome. Serotonin syndrome, I won't cover because it is mainly associated with antidepressants, but sometimes the combination of olanzapine, fluoxetine combination, etc., can produce serotonin syndrome, but because of the time constraint, I will not discuss. First of all, we will discuss what is acute dystonia. You can see from this cartoon, one is dystonia, another is akathisia, another is drug-induced Parkinsonism. Usually, acute dystonia occurs with first generation antipsychotics, at least 1/3 of the patients. 50% of them will have the first sign within 48 hours of the drug intake, mainly the first generation, and within 5 days, almost 90% will have dystonia, provided they are supposed to develop dystonia. Dystonia is an intermittent, spasmodic, sustained, involuntary contraction of the muscles in the face, neck, trunk, pelvis, and extremities. The duration, if you see the cartoon, initially you will get the dystonia, then akathisia, then you will get drug-induced Parkinsonism. Often idiosyncratic, but sometimes dose-related, meaning even a small dosage of first-generation antipsychotic, even 0.25 milligram of haloperidol, in some people can produce acute dystonia. It's greater in males than in females, most common in children, teens, and young adults. It has been reported that substance abuse, especially alcohol and cocaine, may increase the risk. Very, very rarely, acute dystonia, especially drug-induced one, especially with the haloperidol, there are some reports of laryngeal and pharyngeal dystonia. Laryngeal dystonia, imminent respiratory arrest has been reported, but very, very rare. The mechanism of acute dystonia, drug-induced, I'm talking. Basically, there is a dopamine acetylcholine imbalance in the nigrostriatum. Basically, a dopamine hypofunction with a relative excess of acetylcholine. There are reports of dopamine serotonergic imbalance also. You can go through the literature. It is all because of the interaction of one neurotransmitter with others. I don't think that we can discuss the further crosstalks on the neurotransmitter interactions. So you can get oculogyric crisis, commences as blepharospasm, evolves into a painful upward or lateral deviation of eyes. You can have buccolingual crisis. You can have torticollis. You can have even tortipelvic crisis and even opistoclonus. And there is some problem. Then we will come to akathisia. Initially described by Ladislav Haskovic, he was a Czech neuropsychiatrist. He coined the term akathisia. He described, especially in two of his patients, initially he thought that the hysteria or neurasthenia, but basically objective and subjective motor restless. That means inability to stand or still. That is how the word has come. DSM-5 describes as a movement disorder characterized by subjective but observable complaints of restlessness and excessive movements, fidgeting of legs, rocking from foot to pacing, inability to sit or stand or still. Prevalence rates, even 4.6 to over 75% from different type of reports, especially with the first generation is very high. Usually evolves within 2 weeks, but often within hours or after starting or increasing the dopamine dosage of dopamine blocking drugs. So it can be a subjective restlessness and need to move, objective symptoms of pacing, distress if restrained or unable to move. Symptoms may improve during sleep or in a supine position. It has been classified as different stages: subjective akathisia, distress, and the motor one. There are different classifications: hysterical akathisia, spontaneous akathisia. There are some differences with restless leg syndrome or Ekbom syndrome, but especially restless legs more in the lower extremities. And drug-induced acute akathisia, drug-induced pseudoakathisia, drug-induced chronic akathisia type 1 and type 2, I will not discuss. But tardive akathisia, very rarely you can get it, that is a tardive syndrome. Similarly, vitreous akathisia may be a forerunner of even tardive dyskinesia. The consequence of akathisia is non-adherence, suicidality, aggression and violence, can have worsening of psychosis, maybe because of the reduction of the drug or because of restlessness. There is documentation that it can be a forerunner of TD, tardive dyskinesia, if it persists. And also, if there is so much of restlessness, people can get hooked on to smoking or even substances. Akathisia, basically hypertensive antipsychotics, high dose of antipsychotics, or even rapid escalation of the drugs. Advancing age, elderly are more prone. Female sex is documented. If there is a cognitive impairment, if there is iron deficiency, and if there is a previous history of akathisia. Atypical antipsychotics also can produce akathisia, but 2 to 3 times less. Akathisia you can get with the risperidone, with a higher dosage, or both like allopurinol, you can get it. Clozapine 7.3%. You can get with lurasidone. You can get with aripiprazole. Akathisia is the only drug-induced movement disorder that does not have an idiopathic component. Pathogenesis, it's a complex interplay of several neurotransmitter system and brain circuits. There is imbalance between dopaminergic and noradrenergic and serotonergic systems, and also because of the antagonism of mesocortical mesolimbic dopaminergic pathways. I did not discuss this because everybody knows this. There's a GABAergic hypothesis that is decreased. That is why you are giving benzodiazepine, dopaminergic hypofunction, it changes due to dopaminergic blockade, that is dopamine agonist. Some people suggest in very rare cases. Some people, usually there is no need. Acetylcholine, there is a increase because of the balance of dopamine and ACH is tilted. Norepinephrine also is involved. There are suggestions. So the management is dose reduction, switching to drugs which are not to produce less akathisia, beta blockers. How much beta blockers? Propranolol, even 10 to 60 milligram, but depending upon the tolerance, and you can readjust. Anticholinergics and benzodiazepine, rarely dopamine reuptake inhibitors, 5-HT2 antagonist, even 5-HT1 partial agonist, there are suggestions. Current evidence, clozapine is suggested as the first choice of second generation antipsychotic in a patient with a history of akathisia. Beta blockers, though we do regularly, 3 RCTs were identified. Low dose of propranolol 10 milligram 3 times daily. It can be increased 90 to 120, but we don't usually do. Benzodiazepine with a longer half-life, efficacy is uncertain. We usually clonazepam. Anticholinergic drugs, no reliable evidence to support or refute, but prescribed with caution in elderly. Mirtazapine, it is a NASA antidepressant, useful in persons who cannot tolerate beta blockers or if there is a comorbid depression. Cochrane review has suggested mirtazapine has got significant response on akathisia symptom, but not on extrapyramidal symptoms. Other drugs which were tried, amantadine, clonidine, piracetam, and valproic acid, but evidence is limited. Vitamin B6 has been tried, but 1 or 2 studies needs further studies. You can go through the article that in Handbook of Clinical Neurology, the 3rd series, beautiful article in Psychopharmacology of Neurological Disease, 2019. It is worthwhile to read it. Levels of evidence, beta blockers level B, anticholinergics also level B, serotonin-based medication level B, GABA modulators level C, benzodiazepine, though we use this level C, vitamin B6 and N-acetylcysteine, there are case reports, but it is undetermined. What we usually do, beta blockers and anticholinergic, at times mirtazapine. This is the treatment algorithm, nothing much. You are in a second generation antipsychotics. If there's so much akathisia, start with clozapine, slow dose, if they can tolerate, or anticholinergic or beta blocker. Then, if not, mirtazapine, and later desperate remedies. We usually use the scale, Barnes akathisia scale. I think you can go through it. You can read it. Now we'll come to drug-induced Parkinsonism. There is a history of psychotropic exposure. Drug-induced Parkinsonism is usually symmetrical, unlike Parkinson's disease. There's a predominant bradykinesia and less tremor in drug-induced Parkinsonism. Low frequency, high amplitude jaw tremor, and also your classical rabbit syndrome that previously it was called reversible syndrome, or tardive earlier. but it is an acute syndrome, rabbit syndrome, drug-induced Parkinsonism. Anticholinergics are the best known treatment in rabbit syndrome. They do not respond to levodopa or dopamine agonist. In those patients who still have, even if you reduce the drugs, still they develop Parkinson's, have got drug-induced Parkinsonism treatment, otherwise as in Parkinson's disease that you know better. There are differences in drug-induced Parkinsonism and Parkinson's disease, which I have already told you. Drug-induced Parkinsonism, usually it is symmetrical. Parkinson's disease is asymmetrical. Drug-induced Parkinsonism is usually reversible. The idiopathic Parkinsonism is progressive. But anyway, freezing of gait is very uncommon in drug-induced Parkinsonism, but it's very common in Parkinson's disease. The imaging, especially the molecular imaging, the DAT scan imagine cardiac MBG, that is very difficult to pronounce it. Methioidobenzyl guanidine imaging and also transcranial sonography, they are positive in Parkinsonism but negative in drug-induced Parkinsonism. This is the flow chart. I don't think that you will be able to read much, but you can try anticholinergics and drug-induced, reduce the drug and shift to the drugs which will produce less Parkinsonian, secondary Parkinsonism. And what I'm talking about drug-induced, anticholinergics, you can give it. If they don't improve, you can try with amantadine. Then other options, drugs combination, as you do in Parkinson's disease. Rarely drug-induced Parkinsonism ECT is given. NMS, many criteria is there, more than 14 criteria are there in neuroleptic malignant syndrome, Niche-Levinson criteria, Lazarus criteria, DSM-4 criteria, DSM-5 criteria, and Adityanji's criteria, plenty of criteria. But what is there, the classical features are hyperthermia, extrapyramidal symptom, autonomic nervous dysfunction, and altered sensorium. You will have, because of the autonomic disturbance, hypertension and sometimes hypotension, tachycardia, ocular crisis. Sometimes you can have lead pipe, sometimes cogwheeling when there is some tremor, dyskinesia, coriform movement, some people will have dysphagia. There is a rating scale for neuroleptic malignant syndrome written by my own friend Parminder Sachdev that really concentrate on temperature, extrapyramidal symptoms, autonomic instability, consciousness, and movement disorders. The pathophysiology of neuroleptic malignant syndrome, exact etiology is unknown, but dopamine antagonist, if you give it, it can produce hypothalamic dopamine blockade that produces hyperthermia, and dopamine antagonist, because of the mesocortical dopamine blockade, can produce altered mental state. When there's a nigrostriatal blockade, it can produce extrapyramidal symptoms, muscle rigidity, and it can produce increased muscle metabolism. It can produce fever, rhabdomyolysis, myoglobinuria, etc. And dopamine antagonism indirectly. Apart from that, questionable autonomic dysfunction and vasomotor symptoms, labile hypertension, tachycardia, and tachypnea and diaphoresis, very classical. Diaphoresis very classical in NMS. Risk factors, the use of high potency neuroleptic use, we don't see much now. High dose of neuroleptics, one is high potency, meaning having more chance of D2 receptor blockade, because we say for an antipsychotic effect, you have to have 60 to 70% of dopamine blockade, except clozapine. Rapid escalation of the dose. You increase very, very suddenly. Depot preparation, we cannot predict when it will come. So never give depot initially. You have to try oral medication, then only you start with a depot if the patient can tolerate. If there is a previous episode of NMS, there is a chance for NMS. Age below 40, male gender, organic brain disorder. And there are potential risk factors, especially dehydration, exhaustion, malnutrition, postpartum period, and warm and humid environment. NMS can be due to non-neuroleptics. Suppose the patient is on levodopa-carbidopa combination Parkinsonism, sudden withdrawal of dopamine agonist, sudden withdrawal can sometimes produce NMS. Otherwise, metoclopramide, tetrabenazine, reserpine, droperidol, amoxicillin, that's an antidepressant, and amantadine rarely can produce. There are reports of lithium, especially lithium haloperidol combination, phenelzine, very dosulapine, that's dotiapine, even some of the antidepressants, there are some reports. Are they really NMS or are they really serotomimetic syndrome type 3, which will mimic NMS? Serotonin syndrome classification is 1A, minimal plexuseminar thing, and classical serotonin syndrome is serotomimetic syndrome 1B or 2. Then the 3 is, it is almost like a toxic syndrome. It's very difficult to differentiate from neuroleptic malignant syndrome. But there are some features in serotonic syndrome, especially hyperreflexia, opsoclonus, etc., that we in the area we will not discuss there. There are some reports of citalopram and fluoxamine they are facilitating to develop NMS. That is basically the serotonin dopamine involvement. Atypical antipsychotics, there are reports, there are reviews for NMS due to atypical antipsychotics, but incidence is very low, lower clinical severity, and less frequent lethal outcome. In my clinical experience, I had only risperidone-induced NMS. Clozapine, aripiprazole, amisulpride, they have been described, especially cited in the literature, can produce NMS, but they can present with atypical features, means the fever will be less, the rigidity will be less, and they have got a better prognosis. Complication of NMS, everybody knows it. Renal failure due to dehydration, rhabdomyolysis, and infections. Pulmonary complications are aspiration pneumonia, rarely pulmonary embolism, pneumomediastinum. I had one patient who had a pneumothorax and he succumbed. The patient stopped the medication, but patient had severe dehydration, didn't take anything. He came with a NMS catatonic state and he had a pneumothorax and we could not save him. That's my initial stages. Cardiac, you can have arrhythmias and cardiac arrest. I had two patients who had junctional arrhythmias. We could manage with our cardiologist. That's the initial stages. We were using at the time typical antipsychotics, but with atypical, no problems were there. Vascular complication, you can have defined thrombosis, disseminated intravascular coagulation. Neurology, seizures, you can get it, the description there. And there are crown and brain damage described. Others are hepatic failure, hepatorenal failure, etc. How to manage it? It is worthwhile to withdraw the neuroleptic. If you suddenly withdraw a high potency neuroleptic, like pimoside, if somebody is using, it can also generate it. So if there is a NMS, gradually take over and switch over to a neuroleptic with the lowest propensity for the time being. Then stop it, gradually stop it. But suppose the patient is on drugs, suppose you stop it, will it produce psychosis? Usually no, because there is already a dopamine blockade, usually no. What is needed is patient has to be admitted in a neurocritical care. I usually admit in my psychiatric ICU. You have to give adequate hydration, use of cooling blankets. Intake output chart has to be meticulous. Cardiac monitoring has to be done. Nasogastric tube, especially you have to put in a Rice tube. Prophylaxis for DVT and pulmonary embolism, provided you think if there are some signs. Intubation, ventilator support in very severe cases. I had that one only in one case. That was a NMS catatonia syndrome, which was mistaken for a anti-NMDA encephalitis, but dialysis if rhabdomyolysis develops. I haven't had any patients. I have seen only roughly 32 patients, only 2 mortalities in the beginning. All others survived and they are happy. Specific measures, dopamine agonist and benzodiazepine, we'll come to it. Muscle relaxant, people talk about dantrolene, but I have tried only one patient which had to be imported from Dubai. I don't know whether it's available in India now. I don't usually use it. ECT, can we give? We can give, I have given, but very difficult to get a consent and very difficult to motivate. If something happens to the patient and they will blame, we have to really communicate, and rarely anesthesia and plasmapheresis, which we haven't tried. So management is early detection, discontinue triggering agent, supportive medical and nursing care, mild symptoms, gradually stop the medicine, mild symptoms, lorazepam 1 to 2 milligram, IM or IV, but whenever you give IV, you have to be careful. Mild to moderate dopamine agonist, my favorite is bromocriptine, usually 2.5 to 5 milligram. 8-hourly, usually I give through per-orally, very difficult. I usually give it through a nasogastric tube. Moderate to severe dantrolene, I don't give. Severe refractory cases, ECT, I have given in 2 cases. This is the same thing. How do I manage in my patients? I usually admit the patient to neurocritical care or a psychiatric intensive care unit. Along with my colleague, neurologist is Sam, rule out the possibility of autoimmune encephalitis, that is important, especially anti-NMDA encephalitis. We had some cases of anti-NMDA encephalitis, which presented with catatonia and NMS syndrome, but usually there will be a history of fever initially. If you do it and you can observe the classical twitches, then you can go for investigation. Definite criteria for NMDA encephalitis are there. I will not discuss much on it because the another topic in question, the problem, the program, I might be talking on anti-NMDA encephalitis, the current perspectives. Later on, I will talk, not today, another time, how to, what are the differences, etc. Even the usual CSF antibody people talk about it. It is only 50% only. It is you can have a suggestion. Whatever I have sent to your Amarda and others, all mixture, we didn't get any specific answers. So they are all probable. There's a classification, classical, probable, etc. I will not go into details of NMD and stuff like that. Stop antipsychotics, dopamine agonist. I give levodopa carbidopa combination. Any patient who is not on levodopa carbidopa combination earlier in NMS, almost all patients, I have tried dopamine agonist and levodopa carbidopa combination through nasogastric tubes, and most of my patients on the 6th day they usually improve. I have got my own sign called Mary's sign, because Mary was my assistant, so I usually call it. And lorazepam you can give, I have already told you. ECT very rarely, I have given only 2 cases with good results. Though I don't want to say here, I have tried in a critical case, pramipexole, partly, which there are no reports in the world. I discussed with my colleagues abroad. They have told Mohandas, you have to report it. Though I haven't reported it, and did very well. Now, take home in neuroleptic malignant syndrome, suspicion, early detection, good intensive care intervention, most important, correction of electrolyte imbalance, especially electrolytes, one of my favorite area, hyponatremia, hyponatremic encephalopathy. Watch out renal parameters, autonomic instability, very important. It has to be a multidisciplinary team approach. Stop the offender, dopamine agonist, benzodiazepine, levodopa carbidopa combination. If the patient is on those, and certain interval would have produced it. Other patients, I give it with very good results in my patient. I have to say, I've taken enough time because you have to have so many questions. And I have to say thanks. It was a quickie, and certain things that I have to highlight here. I didn't discuss any tardive syndromes. The reason being time constraint. In one of the programs in future, I will discuss on tardive dyskinesia. Some people might ask about dystonia. I think we have to have a half a day to discuss dystonia, different types of dystonia. I will not go into details. But if the questions come, I will try to answer. Okay, thank you very much. Your questions, please. Chintan, I have to mute it now, no, or sir, unmute? No, nothing. Yeah, I need not do anything.
There is a question in the chat box, sir.
Yeah, what is that? Where is the chat box? Attending the webinar, all, nothing is there. Afzal Javed, some problem in logging in. He had a problem. Afzal Javed, my friend, WPA president-elect, he had a problem in logging in. 2 messages, what is there? I am not seeing any chat box questions. Any other question?
Yes, sir. So there is a question from Dr. Sabin. He has asked that
One more thing. One Ramesh Jaiswal to everyone. Voice is not coming. What is the problem?
sir,
Ramesh Jaiswal.
yeah. So sir, there are issues at the other end for the internet stability, but here the voice was there, sir.
Okay. Okay. Yeah. Question? You can project your questions.
Yeah, so sir, there is a question from Sabin who says that we are seeing more cases of NMS in past 2 months. Just today, I had a patient who was on clozapine 150 mg and risperidone 8 mg and valproate 800 mg for past many years, who has developed weakness, fever, and evaluation showing raised CPK from 300 to 1400. Is there any reason for outpatient developing NMS now? I'm thinking about this incident in Chenge series, which was Buento.
No, the question, can I answer like this?
Yes, sir. Yes.
It is a combination, basically, clozapine, risperidone, plus the patient is on valproate. Okay. Valproate is known to produce Parkinson's disease in some people. Okay, doesn't matter. Risperidone is well known to produce NMS, especially even 4 milligram. I had seen patients, if it is 8 milligram or 12 milligram, you can definitely get it. Even all the EPS, hyperplaquemia, with all these things, all EPS, you can get it. Now, there is a possibility. If there is a his seventh question is basically, is there any infection? Can it really precipitate, especially during the COVID season, viral infection? That's a possibility. It may. And infection may sometimes contribute it. And also, hello, even, what is that? Is it okay? Can
Yes,
you hear me?
Yes, sir.
And even the COVID situation, over the COVID situation, some people, because of the neuroinflammation, because of the cytokine storm and other thing, all those people who have got subclinical thing, whether it can precipitate, I don't know, but I haven't seen. Sabin, you have to really observe it and write on it and document it, but you have to investigate. Okay.
Yeah. So second question is from Dr. Bhavna Arora. She asked for the best treatment of tardive dyskinesia.
I will answer it later because this was not in the purview of today's talk, right. Because that will be there in one of series. However, I will summarize in some of the answers in further slides. Yeah, I will answer it later.
Next question is from Sirupudi Srinivas. He asked about serotonin syndrome versus NMS.
It's very easy, basically very easy. Serotomimetic syndrome, usually with antidepressants, rarely with atypical antipsychotics plus antidepressant SSRI combination. And differences are basically, you will get opsoclonus, you get classical opsoclonus. You can get severe myoclonic checks, unlike thing, and there will be a history of diarrhea and classical, what do we call it? Serotonin syndrome, basically because of the hyperserotonemia, but very rarely. Serotomimetic syndrome 1A is bruxism and everything. Serotonin syndrome 2 is the classical syndrome. You know the Steiner's criteria. There are hundreds criteria for serotonin syndrome. The third stage, very difficult to differentiate from NMS, that is type 3. I have classified it to serotomimetic syndrome 1A, 1B, and 1C. Somewhere I have discussed it. But anyway, we will cover it in another days. I do have my slides, but later on I will do it. Yeah.
Yeah, there is a question on, kindly share the reference for classification of tremors.
I will answer that later. I will give you.
Okay,
Yes.
next question
Then
is from Dr. Bharti Challa. She asked that what are the various options to treat oculogyric crisis?
answer I will give you. Details I will give you and reference I will give.
Okay, the next
I will
question
give.
from Dr. Himanshu Gupta. Why aripiprazole cause more akathisia?
Because it has got, though it is a, you can have, it is a dopamine agonist, initially partial dopamine agonist. It is a synthetic one, but there's an intrinsic property of a mechanism of dopamine antagonism, I mean, later on. So it is also, it has got effect of the serotonin mechanism. That is why it has got told partial dopamine agonist with the serotonin mechanism. Rarely it can produce akathisia. Rarely it can produce akathisia, but usually it responds. It's basically because of partial dopamine agonism. But partial dopamine agonism, what is the mechanism? It takes time. Initial stages, when we talk about the agonism, what is agonism? You are talking about the presynaptic receptors. The presynaptic D2 receptors is inhibitory. So inhibition of inhibition, that takes some time to produce more dopamine. And the initial stages, you can get some akathisia because surge, but by the time, within 1 week or 2 weeks, then it really disappears. But you have to start with the lower dosage, then gradually go up. Yes. Next.
Dr. Paramveer Singh has asked, can amantadine be used in drug-induced Parkinsonism?
Drug induced, I have already put in the flow chart. After the anticholinergics, if you stop it, then you can try on amantadine, you can do it. But otherwise, you can do it if a patient doesn't respond after your conventional measures, you can treat as any other Parkinson syndrome.
Yeah, Dr.
Yes.
Aishwarya has asked, any genetic cause for NMS?
There are some reports, but conclusive evidence is not there. There are reports. I will give you the reference also in numbers. Okay.
Dr. Parul Sarma, she asked, any specific management for a patient with akathisia associated with confusion, specifically in the evening? Patient was on valproate 750 mg and olanzapine 7.5 mg and clonazepam 2 mg.
First of all, you have to stop the clonazepam initially. Valproate, you have to see the serum ammonia level, whether the patient has got a hyperammonemia. You reduce and stop it. Then you see with olanzapine whether that's the culprit, you have to lower the dose. Even if there is a small hyperammonemic syndrome, usually people say L-carnitine and other thing as a treatment. My treatment is a little bit different. I usually see that to reduce the drugs and I put folic acid. Folic acid, though it has to be given only, they say that fine, water soluble, etc. Only two conditions you can give even 2-3 times daily. That is thrombotic, some of the thrombocytopenic anemia, purpura, sometimes you can give it. Sometimes you can give in, as an antioxidant, you can give in hyperammonia with the good results which I have seen. Yes. Next.
Dr. Swapnil Agarwal has asked, in patient developing dystonia, do we need to give anticholinergic for short time or should it be continued indefinitely?
Depends. Acute drug-induced acute dystonia, they usually respond to these drugs. Very rarely, isolated patients may even not respond to that. Some people respond, a small group, that's called levodopa sensitive, responsive dystonia, where that's called, that I will come to that. One of the slides I will demonstrate it. That can produce it. Then there is called tardive dystonias. Tardive syndrome, tardive akathisia, tardive dystonia, tardive dyskinesia, all tardive syndromes are there. I will give you the reference where you have to read all these things. We cannot cover everything today because you are not talking about movement disorder completely. Yeah, I will give you the reference.
Yeah, so despite changing or reducing the dosage of antipsychotic, tremor persists even with 12 milligram of trihexyphenidae. We can't further reduce the antipsychotic since the patient will be having severe psychosis.
Yeah, consult with a neurologist and get an opinion. What is the cause? Any other reason for tremors? And I will give you a chart of how to. Tremor was not there in my discussion today, but still I will give you 2 slides on it and where to read. And always discuss with a neurologist. Yes, next.
Dr. Vidya Jasi has asked, kindly give your suggestion regarding the use of muscle relaxant in NMS. How safe is the use of commonly used muscle relaxant like succinylcholine? Please share your experience.
No, 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 no. I don't usually use it and it's of no use. Okay, next.
Is there any genetic uh, predictor for serotonin syndrome, HLA?
There are some suggestions, but not proven completely. Yes.
Okay. Dr. N. Pfizer has asked, can non-psychotic strains cause myalgia, rhabdomyolysis, which could be mistaken for muscle rigidity of NMS?
You are absolutely correct. You have to look into all these things.
Okay.
Pfizer is my friend and he was working with me earlier. Yeah.
Yeah. Dr. Bhavna Arora asked, antipsychotic induced tremors.
I will answer. I haven't discussed today and I will just see and how to differentiate from lithium, somebody, a lithium induced tremor. Huh?
Okay.
Is it that? How to differentiate lithium induced tremor from antipsychotic induced tremor? Is it that? Anyway, I will come to a chart. You can go through it. Today it was not, my presentation didn't include it. I will answer it later. Yeah.
If a patient has
Next.
history of NMS with oral antipsychotic, first generation or second, is this a contraindication for any depot antipsychotic in future?
I have already told you, people have tried, those people who have developed NMS with the antipsychotics and later re-challenge. Some people even didn't develop even after re-challenge, but some people may develop. So it has to be taken with a caution. Suppose the patient was on typical antipsychotics, you can use atypical antipsychotics. If at all you want to have, if a patient doesn't develop NMS with that, you can go with the newer generation depot preparation. If at all you want to do it, their chances are less. Yeah. Next.
Then Dr. Disantar Goel has asked to share references about this topic on his ID. So that is
Okay, I will show you in the picture. Okay, the slides I will do.
yeah.
Any other thing?
Yeah, two more questions. So there is a question, though this is not in the scope. Why does edema fit occur with olanzapine?
That I have already discussed in some of the meetings. Another time we will talk what about olanzapine induced, how does it produce respiratory induced edema, the mechanism. I have discussed somewhere else. I will discuss if somebody wants it. Side effects of antipsychotics. Apart from this, I have got my own that we will discuss later.
Then Dr. Sabin has asked, can contaminants in psychiatric medication cause NMS?
Probably yes. Sometimes the purity of the drug produces. Sometimes when we use some of the drugs, they can produce edema, but the coloring agent, if you just change the brand name, the basic molecule may not produce it. So contaminants can produce it. We don't know exactly whether the contaminants are there. We can produce it because we have antipsychotics here. What is the quality assurance? We don't know. Okay. Next. Any other thing?
Dr. Sachin has asked, do we need to look into the levels of CPK on restarting antipsychotic after NMS? or is it relevant and based on clinical picture mainly?
No, clinical picture, CPK has to be looked into. If there is a very, very high CPK gradually increasing, then that is the most important thing. But the CPK rise may not be that much high with the use of atypical antipsychotics induced NMS. There are isolated cases of even without CPK rise, people have described NMS because there is no rigidity, but a very rare case. But worthwhile to see those people who have developed, get a CPK done, and if there's a level is rising too much, then we have to be careful. Otherwise, no.
Okay, there is a question from Dr. Swapnil Agarwal. Do you recommend adding an anticholinergic and beta blocker initially for few days when starting the patient on second generation antipsychotic for a first time, as it can improve compliance?
Depends. Usual Western teaching is that don't do it, but many people like me, we do it. The reason is we will lose the patient because previously there was a recommendation, even if you give haloperidol, don't prescribe anticholinergic drugs. And later on, they have revised it because the quality of life of the patients will be problematic. So you have to have anticholinergics. But atypical antipsychotics, people say don't use antiparkinson agents. But many of our patients, risperidone, ciprasidone, I have seen patients developing EPS, those people, we have to give it. Propranolol, no need initially. Okay. Yes, next.
There's a question from Dr. Priyanka Gupta. She asked, escitalopram induced akathisia, your experience?
I haven't had any escitalopram-induced akathisia. Very difficult to differentiate whether it is a part of restlessness because of the syndrome itself, whether it's a panic disorder. But escitalopram has got maximum affinity to the serotonergic system. Now, initially, all SSRIs, when we give, the first week, there is a serotonin surge that can produce severe restlessness. And some people are told that this restlessness produces even suicidal ideas. People have told that the SSRI produce the suicidal risk. Some countries, there is a box warning. Now, I usually call it paroxetine paradox, especially when this discussion was there. Usually, when SSRIs are produced, given, when there is a sudden surge of the serotonin in the synaptic cleft, that can produce initial stages along with gastrointestinal symptoms. But later on, within 1 week to 2 weeks time, this disappears. That is why this restlessness, that is, you would have heard about a cricketer in South Africa, what is his name? Pollock. That's called Bruce Pollock regime. Pollock's regime is whenever you start a SSRI, initial stages, you have to start with a small dose of clonazepam, benzodiazepine, within 1 week's time to 10 days, gradually take out. That is called the Bruce Pollock's regime. And by that time, the post-synaptic desensitization happens and the patient will not have akathisia or restlessness. Okay, right. Next.
Yeah, so we have Dr. A.V. Srinivasan, sir.
No, before that, before that, can I just answer this thing with my slides? Can I just show my,
sure,
where are the slides now? Again, I have to go back to the slides. Then we'll, within 5 minutes, I will finish it. So the reference, yeah. Huh?
Yes, sir.
Where slides? This one. Share screen. Post, some people wanted references. Go through in 2020, neurology clinics, go through it. That is May 2020, neurology clinics, 2 good articles. Hassan Bashir and Jagovic is one of the authorities. May 2020, and the scales, Arjun Tarakat. Then Karen Fry, tardive dyskinesia, who gets it and why. You can go through the Parkinson's and related disorders journal 2019. In 2019, September, there's a beautiful article on treatment on tardive dyskinesia, current neurology and neuroscience report. Tardive syndromes, there are classic tardive dyskinesia, tardive dystonia, tardive akathisia, tardive myoclonus, tardive tremors. Somebody wanted mechanism of tardive dyskinesia. It is there. We will discuss later. And some people wanted, what about the new drugs? That's deuterobenazine and valbenazine. These are the VMA2 inhibitors, the mechanism, etc. We will discuss later when we discuss tardive dyskinesia. Dystonia, some people wanted to ask tremor and myoclonus. Always read the book, Movement Disorders in Childhood, second edition, 2016. Handbook of Clinical Neurology, volume 161, 2019. That is a good old the Wing and Ruins book. That is then another one, Psychopharmacology of Neurological Disease. You can get all treatment of all dystonia, tremor, myoclonus, everything. And Amar Patel has put, and Stephen Fruit, Movement Disorders journal. You can go through a good review. Somebody wanted in one of the communication, what about segmental dystonia? There are so many classifications which I cannot go through it. That itself is another talk. Dopa responsive dystonia, some people respond to Dopa responsive, that's called Sagavas, usually young people, and gait, stiff-legged scissor gait, and rarely begins in arm and trunk, dramatic response to levodopa, 100 to 300 milligram. Anatomical substrate, somebody wanted molecular mechanism. I will give you the references. Usually cortical activation, basically inhibition, wide area, especially globus pallidus interna. That is why some people put it, the stimulation of globus pallidus stimulation subthalamic DBS in dystonias. And there is a new theory, so especially involving the interstitial nucleus of Kajal. Now, tremor, somebody had asked, this you can go through the new Neurology, Handbook of Clinical Neurology 2019, essential tremor, enhanced physiological tremor, Parkinsonian tremor, functional tremor, drug-induced tremor, orthostatic tremor, cerebellar tremor, midbrain tremor, all differences, go through it. Somebody wanted myoclonus, somebody asked something on mirtazapine, includes myoclonus. Very, very rarely you have to know that whether it was a forerunner of serotomimetic syndrome. You give the stop it. If you want to give just a cyproheptadine, 2 to 4 milligrams, see that mirtazapine induced myoclonus, that will disappear. Myoclonus, other details I will not discuss. There are neuroanatomical substrates which you can go through and read it. Some people ask on Lewy body disease, read Molecular Mechanism of Dementia, new book 2019, and International Review of Neurobiology 2019. Somebody had asked of ocular crisis. Please read Parkinson's related disorder journal 2019, whether you can get even, can you get it even how to differentiate ocular crisis, even whether you can get even prolonged one, some other things. Somebody has asked, I think my friend Ashish has asked about Meek syndrome. That is Pandey's article in Journal of Neurological Sciences 2017. Go through it. And somebody asked why there is a neural hypersensitivity in Lewy body Dementia, basically dopamine neuronal loss is substantia nigra pars compacta that produces not only hypersensitivity but instability and faults. There are many other reasons because of the alpha synuclein mediated induction of oxidative stress and neuroinflammation and cortical thinning, occipital hypermetabolism, etc., etc. You know it. Other question, my friend withdrawal dyskinesia, Vibina asked, withdrawal dyskinesia is a subset of tardive dyskinesia. In some people, you can get it. You have to correlate the supersensitivity psychosis. I will not go into that. Lowest dose of haloperidol to produce NMS. I haven't seen much literature, but lowest dose of risperidone, even 0.25 milligram in a small child has produced NMS that is described. Movement disorder centers in India and abroad. India, as you particularly in Bombay, my friend Mohit is there, in Chitra, Asha Kishore is there, and many other centers, neurology, you can discuss with neurologists. Abroad, our own friends like Kailash Bhatia and others are there, you can discuss with neurologists. New theory of NMS, Srinivas wanted to talk, and here is Srinivas, sir. It is your turn. Okay, Srinivas, your turn, sir. New theory of... Yes, A.V. Srinivas, sir. Click to exit. Exit. How to? Okay. Is it okay, sir? Chindan?
Yes,
Any
sir.
other thing? Now,
Yes,
Srinivas sir can talk. Afzal, no, Dr. Afzal has joined.
Yes, sir.
Just, Afzal, before Srinivas, can you just put your remarks as WPA President-elect? Afzal?
Well, thank you.
Yes.
Thank you very much, Dr. Mohandas, and thanks to Torrent for organizing this very, very informative meeting. I can't comment more than this, that as usual, we had a very good presentation from Dr. Mohandas, who covered all the relevant topics and the areas of this particular issue in a very, very exemplary way. I think just two comments. One is that as psychiatrists, as we are moving more towards functional psychiatric disorders, many of our younger colleagues are now going away from the organic or the neurological basis of many of the symptoms and syndromes that we share with other specialties in medicine. This is very important, and this akathisia, dyskinesia, movement disorders are very important topic in clinical psychiatry. The second thing which I would really like to suggest, I was looking at the list of the questions. I think these questions are a presentation on its own, because these are the questions that have been asked from the experienced clinicians. So I would recommend Dr. Mohandas that a new presentation can be just based on answering the questions which are very, very appropriate and relevant. And last but not the least, I'm grateful to my Indian colleagues for doing and continuing with this educational program. And I hope that World Psychiatric Association can rely and can come to you for similar type of meetings, not only for the Indian psychiatrists, but also from South Asian psychiatrists and psychiatrists from many other low and middle income countries. Thank you, Mohandas, and thank you, Torrent.
Okay, thank you, thank you, thank you. Now, boss, Srinivas sir, your theory.